Tonight's speaker is, tonight's speaker is Dr. Jennifer Guyther. Dr. Guyther started with Baltimore County in 2001 as a volunteer at Jacksonville Volunteer Fire Company in the northeast part of the county, and has been with us ever since because once it gets into your blood, you can't escape. She is a graduate from the University of Maryland Emergency Medicine and Pediatrics Combined Residency Program in 2013 and has remained on faculty there as an assistant professor in both the departments of emergency medicine and pediatrics. She is also a co-director in the residency for emergency medicine and pediatrics. She's very active in EMS. Many of you know her as the deputy medical director for Baltimore City Fire Department, or the assistant medical director for Baltimore County Fire Department, or as the associate medical director for Region 3 for MIEMSS. She works in many areas. She's very active. Her topic tonight is going to be on the pediatric trauma arrest, little people, big trauma. So without further ado, I pass this to you, Jennifer. Thank you very much for being here tonight.
All right, thank you guys for having me. So this is a really kind of exciting topic. It's a topic that a lot of people don't enjoy talking about. They probably don't enjoy actually having pediatric patients that are in cardiac arrest, and some of you may not even enjoy taking care of children. But hopefully tonight, what we're going to do is take a look at the sick pediatric patient related to trauma and then the evolution into trauma arrest. We're going to talk about some of the things that you can do, how to assess the patient, things like that, and some of the newer kind of discussions that are coming out. So we'll bring up TXA, we'll bring up whole blood, we'll bring up some ultrasound, and it should be good. Feel free, if you have questions, throw them in the chat. If you have questions afterwards and want to send me an email, I somehow love to talk about cardiac arrest. I don't know why, but I do, and I'm always happy to continue the conversation. So I have no financial disclosures, but we are going to talk about things that are not within protocol at this point. And I can hopefully be able to tell you why they're not in protocol yet, or if in 10 years we're going to be seeing them in protocol. But please don't tell Dr. Chismar or Dr. Nussbaum that I told you to do something, because I don't want to get in trouble and they're my friends. So please don't do that. The other thing, if you guys haven't downloaded the protocol book onto your phones, even if you're a skeptic of the technology of MIEMSS at the current moment, it is so user-friendly, even if you have an Android phone like I do. So great reference, so much quicker than looking through the protocol books. If you're trying to think about what is that age-based dose of pediatric epinephrine or something like that, it really is at your fingertips. Very nice compliment to the Bernius card, which y'all have as well. So there's a lot of different thoughts about children in the setting of taking care of them. Some people will say, oh, kids are just little adults. Some will say adults are little kids, which may or may not be true. Some will say pediatrics is veterinary medicine. But whichever one of those kind of thought groups you belong to, there is probably a middle ground where you can treat some patients like an adult. And it's really good to figure out which kids you can treat like an adult, i.e. a 14-year-old. It's probably okay to follow all your adult protocols with a 14-year-old. But there are some nuances that you need to recognize. And once you recognize them, you will slowly get comfortable in treating the patients who are much smaller and more compact. So unfortunately, pediatric trauma is becoming more and more common. And I'm going to say the olden days, but like 10 years ago, we were not talking about kids getting shot on the corner who were not stereotypically involved in drug deals or gang-related activities or things like that. But now it's becoming more and more common for kids to suffer from penetrating trauma. And the literature is just not there because fortunately it hasn't been going on for long enough for us to get a large population to be able to figure out how to treat a kid who was stabbed or shot in the stomach with evidence-based medicine. And so what has happened with a lot of our trauma literature is it has been proven in the adult world, and we have slowly adapted it to the pediatric world. And that's a lot of what you will see with the way we take care of kids is people proved it was safe in adults, and then they try to figure out whether or not it's safe in kids. And these are just two kind of things that pop up on the news that I take screenshots of when I come across it for when I give presentations like this. But these are just both from this year. So very common, unfortunately. So we're going to take a closer look at this. And I liked this visual because there is so much information here. And it's kind of nice to get an overall sense of pediatric trauma in the US and kind of the numbers with it. So if you look at just this main picture in the center, one child is dying from a traumatic injury every hour. Fairly horrible statistic. And this is just US based data. So you wind up having about 10,000 deaths, a little under, from traumatic injuries a year. And if you go over here, about 6,000 are unintentional. So they break it down. Half of them are car accidents, right? That's a lot of what you see. Drowning, and I'll say this probably a couple times through this lecture, drowning is its own category. Doesn't kind of play well into the trauma guidelines. It doesn't play well necessarily into the medical guidelines. So I always like to think of drowning as a third semi-traumatic related event. But you then have poisons, firearms, falls, and then unfortunately you have about a third of your pediatric deaths in the US from trauma are related to either homicide or suicide. And that includes kind of your non-accidental trauma kids. Pediatric trauma takes up a lot of money. So non-fatal hospitalized injuries, this is from a couple of years ago, but had an annual cost of $24 billion. And that is not just the cost of the kid going to the hospital and getting their care and their resuscitation, but that kid goes to rehab. That kid then needs, if they survive, they need so many intensive services at home. Their parents are unable to go to work because they're taking care of their kid and kind of the long-term costs. So it's a very expensive thing to have happen, especially if you survive. And overall, when you look at kid trauma versus adult trauma, significant pediatric trauma is about 10 per 100,000 population. Adult significant trauma, about 75 to 80 per 100,000 population. So much, much less, but very costly because these kids, they're little. They're going to live much longer than grandma who fell down the steps and broke her hip and things like that, because grandma's 70, 80 years down the road from when this kid suffered their traumatic event. Federal research dollars, not as much goes into it. Certainly a lot of money goes into cancer, which is wonderful, needed, excellent, and things like that. But when you compare the money going into cancer to the money going into research for childhood injuries, you have $17 versus 18 cents. So fairly significant. The other cool thing about this picture is take a look at the level 1 pediatric trauma centers. So there are 42 in the country. If you think about it, we have 13 hospitals within kind of 10 miles of the center of Baltimore. Don't count my math, but generally, right? Compared in 2 trauma centers within our reach, one really close, the other one, you can argue whether DC is close or far, but there are 42 in the country. And the East Coast is really well populated. You're very lucky if you live, in Maryland, Pennsylvania, Delaware. We have a lot of trauma. If you come out to kind of the middle upper part of the US, in these 5 states, there are no pediatric trauma centers whatsoever. So if you want pediatrics as specialists, if you have a kid, who's 2, so very different physiology than your adult counterparts, who is ejected in a car accident or something like that, if you want them to have the pediatric expertise of pediatric trauma surgeon, you're going to have to fly them, right? You're not going to drive from the Canadian border 2 or 3 states down just to be able to get to a trauma center. So it's very interesting to think of who is actually taking care of your child and what training they have if there is an injury, especially if you guys are going to go outside of the Baltimore region and be able to practice. So as we talk today, we're going to look at the general approach of the pediatric kid who has suffered a significant amount of trauma, not just I fell off the monkey bars and my arm is pointed a different direction. That's a totally different lecture. Then we're going to talk a little about hemorrhagic shock. I'm going to introduce or maybe reintroduce to you the FAST exam. We'll talk about TXA, tranexamic acid. We'll talk a little bit about massive transfusion and what is best and what has been shown to work in the pre-hospital setting. And then we're going to get into traumatic arrest and look at the role of epinephrine. Is there a role for termination of resuscitation? Is there a role for mechanical CPR, for REBOA, and for thoracotomy? And we'll talk about needle decompression in there as well. So while we go kind of over the next, I don't know, hour and a quarter, hour and a half, give or take, I want you to think about this case and see what exactly you guys would do in the field with this patient. So you get a call for a 9-1 cardiac arrest, dispatch, and on arrival, the police have gotten there first. They found an 11-month-old in the sink. They were wet. They were not breathing. They did not have a pulse for the police. The police started CPR. Of course, it's an apartment building, so the police run down the steps. They meet the engine crew. By the time they give the kid to the engine crew assesses, and the kid's not breathing, but they do have a pulse. And then they, of course, walk them out because they're in the middle of the stairwell to the medic, where you are finally able to assess the patient and you agree that they're not breathing. They do have some blood on their face, but they do have a heart rate that is a little bit bradycardic. You go ahead and you can't get the story. There is a language barrier on scene, so you don't really know exactly what happened. You can't figure out why the kid is wet, why the kid has blood. They're not like outside at a pool. They were inside an apartment building. The police didn't give you any history that this was a drowning, so don't go there because different topic for different day. And you consider that maybe there was some sort of trauma given the blood. You try to put your commercially available cervical collar on the kid. It, of course, does not fit, so you jerry-rig something and transport to the hospital with an IV in place. On the way to the hospital, the patient starts having some decorticate posturing and it becomes a little bit more bradycardic, and then arrests. And so that's kind of arrival to the hospital, and you wind up transitioning care, and then you got to clean up your medic. All right, so what are some of the key differences with pediatrics compared to your adult counterparts? What's nice is this is going to be alphabetical. So one of the key differences is airway. There's a bunch of different anatomical differences, kind of go back to your anatomy and physiology class a little bit, right? The airway in kids is much more cone-shaped. So things, for one thing, are going to get stuck. You also have, if they have kind of the URI croup, it's going around right now, it's horrible. Their airway is going to get more inflamed, can certainly have more issues just related to its smaller size. The uvula is a little bit more floppy, things like that. So anatomical differences. Intubating a kid, very, very different than intubating a grown-up, especially when you don't normally intubate the kids. For breathing, you have to remember age-appropriate vital signs, and this, I think, is the bane of most people's existence when they're not used to dealing with kids. So a heart rate of 170 for a crying 1-year-old is totally fine, or for a febrile 1-year-old. If you saw a 23-year-old who walked in with a heart rate of 170, people would be freaking out and putting them on the monitor and, further assessing them. So having whatever reference you want to use for age-appropriate vital signs is key. So the Bernius card is great. If y'all like the PALS card, all of them are going to be the tiniest bit different, and that's okay. You just want to get the gist. And the smaller the patient is, the higher the heart rate can be. So kind of figure out what the trends are. Kids are also, they really enjoy breathing, right? Adults really enjoy breathing too, but when kids stop breathing, they can become hypoxic really easily. They have a much smaller functional residual capacity for their lungs, which makes sense because they're tinier, right? So they become hypoxic easy. When they become hypoxic, they then become bradycardic. When they become bradycardic, they try to die on you, especially when they're much littler. So if you can make sure the airway is open and make sure that they're breathing adequately, you are going to kind of be able to steer clear of, maybe prevent, maybe delay their heart rate from dropping and them decompensating in that way. All right, circulation. Hypotension occurs late in kids. So within the setting of trauma, kids can lose up to 40% of their blood volume before they're going to become hypotensive. And if they present hypotensive, they have a greater than 13 times increase in their mortality from their injury. So if you have a kid that presents who's maybe 5 years old and their blood pressure is 70 systolic and they don't look so good, they maybe flipped themselves over the bicycle handles and then continued to roll down the hill and then got hit by a car, and they're hypotensive, they need to get to a surgeon, to blood, to kind of further resuscitation very quickly, because that hypotension means that they have completely fallen off the cliff. Kids also, because they are just smaller people than grown-ups, they have a smaller total blood volume. So if you go up on the scene and you see a puddle of blood underneath their head, that puddle of blood may be a significant amount of blood for that patient's body size, compared to if you saw that same amount of blood underneath a grown-up's head. And then we'll talk a little bit about fluid resuscitation and access. A lot of people are not necessarily used to putting like 22 gauges, 24 gauges into a 1-year-old's hand. So we're much quicker to jump to IOs, which is wonderful. But then some people are scared of putting IOs in on, I was going to say living, but awake children, which is a very reasonable fear. But we'll talk a little bit about why it's important. Then you're going to have to know, right there, D for disability, can cover some other things too, but you want to know an age-appropriate neurological exam. This can be an important one if you're assessing their GCS, right? You got to know when they can talk, when they can't talk, when they can babble, when they can't babble. When are they supposed to sit up? When are they supposed to be able to roll over? If you have a 1-month-old whose parents state that they rolled off of the changing table, in general, rolling is not a 1-month skill. Yes, it can sometimes happen, especially in kids with higher tone. So it's not impossible, but in general, your 1-month-old baby should not be doing kind of flips across the rug or things like that. So if I had a baby that was 1 month that felt that the story was they fell off the changing table, my suspicion for non-accidental trauma has shot up a little bit. For GCS, there's a lot of research looking at, can we just use motor GCS in kids? A lot of the current studies that are out say, yeah, which is great, because then you don't have to figure out their eyeballs, and you don't have to worry about figuring out who babbles and not in the pediatric GCS compared to the adult GCS. So if you just wanted to calculate your motor GCS, beautiful. That being said, your 1-month-old is not gonna, if you say squeeze my hand to the 1-month-old, not gonna work. You guys know this if you've been around kids. Cervical spine immobilization can also be different when the person is super small. I'll show you a picture in a little bit. And outside of your neurological exam, the other D can be for dextrose, so hypoglycemia. Kids, especially littler kids, have low glycogen stores, so their liver doesn't store glycogen as much, and they have such an increased metabolic demand that they go through sugar quickly, so they will become hypoglycemic much faster. They will also become hypothermic much faster. So as you are assessing the patient, which you should, right? All the clothes should at some point come off. You want to be able to cover them back up as you go, or be sweating in the back of your medic because you've turned the heat up so high. Kids also, when they become hypothermic, they tend to become bradycardic and try to die as well. And then I have thrown F in there because most kids will come with some sort of family member. And sometimes the family is amazing and very helpful, and sometimes the family is freaking out and is not helpful whatsoever. So being able to figure that out and where you can place the parents so that they are helpful to the situation and not hindering the patient's care can be a little tricky sometimes. So these are just some kind of vital sign tricks that may or may not work for you. I personally am not a good mnemonic person. I just memorize everything. I don't recommend following the way my brain works with that. But here are some tricks. I don't have a trick for heart rates. If anybody does have tricks for remembering pediatric heart rates, I am happy to share them with everybody. I just don't have any. So when you're looking for hypotension, the general kind of rule is 70 plus twice their age in years. The thing is, this is the 5th percentile for hypotension, which means that 95% of the people normally running around are supposed to have higher systolic blood pressures than this. So some people will suggest that you should calculate what their blood pressure should be based on the 50th percentile, which is 90 plus twice their age in years. Just kind of a quick and easy rule if you are able to get an accurate blood pressure. Getting an accurate blood pressure on a patient who is fighting you may or may not work well. But if the patient's unresponsive, getting that blood pressure, or if they're lethargic, getting that blood pressure can be really important. And I'm going to be much more likely to trust that blood pressure than an elevated blood pressure in a kid who's kicking and screaming. We don't care, I'm going to say it anyway, we don't care as much about hypertension in kind of the first 5 to 10 minutes of the event. Certainly it can be a sign of head injury, things like that. But hypertension in kids will be, for a systolic, is 100 plus their age in years. Their systolic should not be greater than that. Kids less than the age of 1 will have a generally open fontanelle. So the anterior fontanelle will close by 1 year. There's posterior fontanelle as well that will generally close by 6 years, or 6 months, excuse me. Those are like little pop-off valves for pressure. So if you think of a kid who hit their head, who has a intracranial bleed, when they have the anterior fontanelle that's open, they have a pressure valve, kind of like the turkey little cooker thing that tells you the temperature. So their blood pressure is not going to fluctuate early because they have that pop-off valve. Once that skull is fully fused, similar to your adult patients, their brain starts to swell, there's blood in their brain, something like that, they will then start to become more hypertensive with that increase in pressure. And that's where you can start to look at significant hypertension. That significant hypertension is not going to be like 101 for a 1-year-old. It's going to be like 130s, 140s, something like that. In general, your kids' blood pressures are going to be much lower than the general adult populations that we see. For me, when I'm on the adult side, the vast majority of my patients, I swear, if they have a systolic of 160, I think that they're about to die, because that is most of my patients 180s, 190s, 200s, but that's what happens in my population. For breathing, the upper limits, if you like to kind of remember trends in numbers, for a kid less than 2 months old, their breathing rate should really be less than 60. You go to 2 months to a year, less than 50. By toddlers, no greater than 40. In preschool age, no greater than 30. And by school age, and kind of similar to your adolescents and your grown-ups, you want less than 20 for the respiratory rate. Now, I'm not sure how familiar you guys are with shock index. We've started to kind of introduce shock index to EMS over the past couple of years, and mainly in the adult population. Very easy to calculate. You can always pull out your calculator, but it's shock index in grown-ups is calculated heart rate divided by systolic blood pressure. So 2 vital signs that are easily available to us. And for adults, if that ratio is greater than 0.7, then they are in shock. And these are clearly in your people who are at risk for shock. Now, they've tried to figure out whether the shock index can be applied to pediatric patients, because the caveat is that kids' heart rates are all different, right? Like maybe we could argue that systolics are not all that far off, but heart rates definitely far off. So they came up with the shock index pediatric adjusted, SIPA is what it's also known as. And they came up with criteria in years. So if you are between 4 to 6 years old, this does not work below the age of 4, and your ratio is greater than 1.2, issues with shock. 6 to 12, if it's greater than 1, issues with shock. And greater than 12, kind of 0.9. And then once you get into adulthood, whether you want to define that as 15 or 18, greater than 0.7. Some studies will also say 0.6, really just depends what articles you read. But what they found when they used the SIPA, so the pediatric version of this, is that your patients where the score was elevated had an almost 4 times odds of major trauma compared to those with a normal value. Now, does this apply to EMS? You guys are going to say, wow, this kid's heart rate is, 140 and their blood pressure is 80 systolic. And they just were in a horrible car accident. You guys are going to recognize that that child is sick. So I don't know how much calculating the pediatric SIPA score is going to help you identify that. Ultimately, when they look at kind of calculating injury severity scores and prognosis and kids that go to the ICU, they calculate a lot of these scores. But for EMS, I think if you just know that if their heart rate is significantly greater than their systolic blood pressure, I would probably worry that there's something going on with the kid. Now this picture, there has to be like 3 different pictures in the world of people using the Broslow tape, because every time I go and try to search for a new one, there is none. There's like 2 other ones, and I always liked this one the best. Broslow tape is a great resource. Any length-based resuscitation tape, whatever it is, there's a bunch of different versions out there, but this is helpful to kind of have that cognitive offload of, let me lay this out. Let me figure out how much the kid weighs. Guess what? My drug doses are generally written on there. My equipment size is written on there. And depending on what system you are with, you may or may not have the color-coded Broslow bags that go with it. That just kind of varies across some of our different jurisdictions. But length-based resuscitation tape, beautiful. And we mentioned earlier that sometimes the cervical collar doesn't fit, and that is okay. In this wonderful picture that was clearly somebody's kid somewhere on Google, they almost look like they're trying to strangle him with the towels. They're not, but kind of patting and kind of making a U-shaped circular device around the neck with either towels or sheets rolled up is acceptable when your C-collar doesn't fit, because the last thing you really want to do is wind up hyperextending these kids' necks trying to fit on the manufactured C-collars when you have the suspicion that something is going on. There is a, can't think of the right words, but when you guys put a C-collar on in the field, there have been studies that show that that increases the rate of imaging that is done when they come into the emergency department. And so there's that diagnostic momentum. That was the word I was looking for. And so when you guys C-collar somebody, chances are now the physician or the nurse practitioner or the team who is seeing them is going to say, you know what, they put this on for a reason. They must have thought the mechanism was severe enough, or the kid was showing signs of neck pain or something like that, that now I am probably going to get an x-ray, get a CT. Now, in general, pediatricians hate CT scans because CT scans mean radiation. We're not worried about the 80-year-old lady giving them cancer. They're going to die of natural causes long before the CT-induced cancer gets them. But kids have a long life ahead of them. And depending on what study you read, what body part you're doing, what brand of CT you have, the risk of cancer 20 years down the road is anywhere between 1 in 200 scans to 1 in 500 scans, which if you're seeing a lot of patients can add up to, giving a couple kids cancer. So we take CT scanning very seriously in pediatrics, a lot more seriously than we take it in kind of the adult world. There are certainly cases where no question the person needs a CT scan, and that is fine. There are some really good researchers that are trying to figure out ways and rules to follow that are good rules of when you need a CT, when you don't need a CT. And the it's actually an international organization, but PCARN is the Pediatric Emergency Care Applied Research Network, which is a group of mainly tertiary, quaternary pediatric hospital centers. It includes some international groups as well who collect data. They're very smart people. They've got lots of researchers, lots of statisticians to be able to interpret that, but they also have lots of patients. And so when you do a study at so many sites, you can get lots and lots of kids. And kids are one of the protected populations, right? You can't really do research easily on prisoners, pregnant people, and children. And what's nice is that PCARN can create these very large databases and come up with rules and then validate those rules within that same database. So the cervical spine imaging rule just came out maybe a month or 2 ago. Very exciting for a PZD person. But basically, they had 22,000 children in this study. And these rules haven't applied to EMS yet. Well, it's only been out 2 months. Right now, it applies to when to get nothing versus X-ray versus CT scans. But now they are looking at that data and figuring out if we can refine our cervical spine rules for EMS, so that in this group that has no risk factors, no high mechanism, can we tell EMS just, hey, in this kid, you don't need to put a cervical collar on, so that there's not that diagnostic momentum when you roll in, and the kid's not fighting you, because, putting a C collar on a 4-year-old who was just running around in circles and is screaming is not a pleasant experience for you, the kid, and or probably the kid's neck. So nothing to know or memorize from this particular slide now, but it's going to be good in the future. And hopefully it's going to make a change at the protocol level. Currently, the National Association of EMS Physicians and the College of the Pediatric College of Surgeons, Pediatric Trauma Society, are working together to revise the national guidelines related to cervical spine immobilization in kids. And so that's why Maryland hasn't moved on it yet, because we don't want to move on this now and then in a year revise it again, because it would just be confusing for everybody. Now I talked a little bit about IO access, or needing to have some sort of IV or IO access if you need to give the kid medication and or fluid. The proximal humerus is not going to be fully formed until they are anywhere between 6, 8, and 10. Really depends what study you read, what the growth rate is of the particular kid. So in general, when they get to their teenage years, by all means, use the proximal humerus. But other than that, you're going to probably stay in the legs themselves, with the proximal tibia being the most recommended and most used. You can also use the distal tibia as well. What you will see entering protocol next year is the indication for the distal femur as an alternate site. And that just passed protocol review committee yesterday, I think was Wednesday. And it will, of course, go to SEMSAC and the state EMS board and things like that before final approval. But the distal femur will be a lovely addition to our protocols, assuming all goes well. And if anybody's interested in going to protocol review committee, they're open meetings. We love people chatting, so feel free to come. Now, where did the idea of femoral IOs come from? There has been some literature in the adult world, but a lot of literature in the peds world, because the success rate of tibial IOs, the proximal tibia, you can get them in 70, 80% of the time. Their failure rate is up to a third wind up failing. So it's a tiny bone. It's a tiny target. The femur, bigger target, a little bit of a bigger bone. This study came out a couple months ago now, maybe last September, published in September, down in Broward County, Florida. They have been using femoral IOs since 2018, 2019, give or take. And so they were able to do a retrospective study just looking at kids who got IOs in the distal femur versus the proximal tibia versus IV, and compare them. And really, you can see these were mainly kids in cardiac arrest. They didn't separate it out, medical versus trauma, but it doesn't matter in this case, because you're just looking at, is the distal femur a good site, or a site that can be used without increase in complication rates? And what you'll see is, 82 distal femur attempts versus 72 proximal tibia attempts. Successful in the distal femur 89% of the time compared to 84% of the time with your proximal tibia. And the rate of complication was only a difference of one actual case. So several other small studies kind of support the proximal femur being a safe place. A lot of times you can also get a faster flow rate, just a little bit of a bigger marrow space as well. All right, so switching gears a little bit to destination choice. So do you want to go to the adult trauma center over here? Your peds trauma center is in pink and purple. Which one do you want to go to? So there have been a bunch of different studies, all of which support that if you are a kid, you do better at a pediatric trauma center. And we're going to define kid for this anywhere between 0 and 14. So most of the studies will say they had lower emergency department mortality rate and lower inpatient mortality rate when they were treated at the pediatric trauma center. They were also more likely to be discharged home earlier with fewer ICU days and fewer vent days than if they remained at an adult trauma center. When they looked at the kids that were 15 to 18, so in that I'm technically still see my pediatrician range, but in the adult world of trauma, I am an adult. Those kids did equally whether they were seen at a pediatric trauma center or an adult trauma center. Now, what about if you don't have you're in the middle of the country where the map of the US was, and you don't have any trauma centers near you? Well, what they are looking for when they're going through and doing their redesignation of trauma centers is to make sure that all of the adult trauma centers or the only trauma centers are pediatric ready. So similar to we have pediatric ED readiness, they're looking at pediatric trauma center readiness, and it's actually slowly getting incorporated into their recertification process, which will be excellent. And mode of transportation, not as controversial, hopefully, as you would be if you were in the middle of the country. When you are far away from a pediatric trauma center, you need to kind of balance the risks of flight, the time of flight, the intensiveness of flight with going by ground, possibly not to a pediatric trauma center, depending on where you are. When they looked at the number needed to fly, it was about 1 to 40 to make a difference in patient outcome from flying a kid to going by ground. So there are a lot of different factors that need to be taken into account when you're looking at flying a kid versus driving. I would say when your trauma center is within 30 minutes of the drive, you're probably still going to do well driving the patient there. And depending on if you're in another system, that helicopter may also have resources that you don't have. Rapid sequence intubation, blood products, things like that, that may actually make a difference in the patient outcome, which may push you one direction or the other. Please don't fly people from Towson to Johns Hopkins. I don't want to do that QA review. So we've talked about kind of a bunch of little things in that initial patient assessment. We have gone alphabetically. Remember, grown-ups, we sometimes go out of alphabetical order, but in the kids, always go in alphabetical order. So now we're going to talk about some of the interventions that you guys can do in the back of the medic and or on the scene. And then we're going to talk about traumatic arrest. Ultrasound. So ultrasound is up and coming, and it's been up and coming in EMS for the past couple of years, in pediatric emergency medicine for probably a little more than a couple of years, and in emergency medicine, I would say for about 15 years. It really started heavily in kind of the 2010 era. It was around before that, but not as aggressively as it is now. And I will say my residents are much better at ultrasound than I am, and I still was able to have ultrasound training back in residency. When certain, some of our surrounding jurisdictions outside of Baltimore have ultrasound. Baltimore City, we physically just got the ultrasound that had been ordered for the past 2 years. We just got it last week, and are now actually figuring out how to implement it and get the technology to work and things like that. But in addition to using on your adult patients, there are definite uses in pediatric patients with medical cardiac arrests, traumatic cardiac arrests, pneumothoraces, and then in the setting of trauma, the FAST exam, which is the focused assessment. It's going to come to me in a minute. I'll repeat it in a second. But either way, the FAST exam. And there's a lot of controversy surrounding pediatric FAST. If you guys are familiar with taking a patient to shock trauma, a grown-up patient, after the anesthesiologist who's at the head of the bed secures the airway, does whatever they're doing to the airway, there is somebody doing a primary survey, there is somebody doing a secondary survey, and you will see the other person with the ultrasound, and they are going at it. They are taking a look at kind of all the quadrants that are pointed out on this little baby right here, and they are figuring out whether there is blood or no blood. If there is blood, that's not really that great. If there is no blood, they could still be bleeding. You might just not see it yet, or they might be totally fine. You can get serial exams. The literature in pediatrics is not as robust, and kind of a blanket use of abdominal ultrasound looking for blood is not as well studied and not as accepted. You have a bunch of different literature that you can look at. One is the emergency medicine literature, and we love ultrasound, and so we love FAST exams, including in kids. Then you have the pediatric surgery literature that says we hate ultrasound. We don't believe in it. Why are you doing it? And then you have the pediatric emergency medicine literature that kind of melds you together and said, you know what, if it's positive and I take it in context of all these other things, it can probably be helpful as long as I don't fully trust a negative scan as saying the kid is perfectly fine. So there's a lot of still medical controversy on it, but we can use it in kids. Kids do not present with free fluid as often as their adult counterparts, and so it can be a little tricky. What you're seeing kind of down here, these black lines is between the kidney and the liver, and then the lung is up here with the diaphragm here, the lung here. These dark black areas in these particular pictures are signs of blood. So this person would have blood both above and below the diaphragm. And then in this is a right upper quadrant, liver, kidney, and the free fluid is here. The pictures that I have at the top of the screen are for looking for pneumothorax. And so you can actually see lung sliding on your ultrasound and determine whether in that particular location, you do need to take a look at multiple different areas of the lungs, but in that particular location, is there lung sliding, which is beautiful, that's what you want, or is there no lung sliding, and things like that. So you have the sandy beach, which is lovely, versus the not so sandy beach, which is not lovely and would get a needle. This is the way, more just for reference, one approach to using the FAST exam. And as a part of your primary survey, if your kid is hemodynamically stable, and again, this is all in the ED, this isn't necessarily what you're doing in the back of the unit, but you could be ultrasounding in the back of your unit one day. And if you see a positive FAST, driving maybe a little faster to the pediatric trauma center, or if you're making that decision of, can I go local or can I go to the trauma center, and I see what I suspect is blood in the belly, you're definitely going to the trauma center. Things like that. This could be a whole, like this slide could be a whole lecture in itself, which I'm not going to kind of bore you too much with at the moment, but if anybody wants to talk more about ultrasound, I'm more than happy to. So you do your primary survey. If the kid is unstable, you're doing lots of things. You're giving them fluids, you're giving them blood, you're doing blood work, you're getting your surgeon involved early, you're continuing to resuscitate them. Maybe then I'll fast kind of as people are deciding and figuring out, are we going to get imaging or are we not going to get imaging? But if your kid is stable, they're looking at you, they're kind of moving, all their extremities good, their vital signs are reassuring, I can maybe do a fast on them really quick. If it's positive, well, I'm jumping the gun and going to call the surgery team to come and evaluate before I fully figure things out. But if it's negative, I might do blood work. I might observe. I might get a CT depending on the blood work results and things like that. So this is where the FAST exam would fit into my workflow in the hospital. But in the pre-hospital setting, you may be able to use it as well. Where it's really, I think, going to have the biggest impact is the lung and heart exam. So you can look for with the heart pericardial effusion, which is not what we're talking about today, but one day we'll talk. So outside of ultrasound, which would be lovely in the setting of trauma, one thing I think people often forget is to treat their pain. If they're unresponsive, that's a different ballgame. But if they are tachycardic, are they tachycardic because they're scared? Reasonable. Because their leg is pointed in the wrong direction? Reasonable. Or because all their blood has left their vasculature and is floating around in their belly where it's not supposed to be, which would be bad. So in addition to making the kid maybe stop crying a little bit, making them more comfortable, you may also be able to see if some of their kind of tachycardia resolves a little bit. And you can use fentanyl, you can use morphine, you can use ketamine, all within kind of the indications of protocol. But it is okay to treat the pain. There's a ton of EMS literature saying that we don't treat kids' pain well, and lots of different reasons behind it. But I will tell you, even in like the isolated extremity trauma patient, it takes us, even if we know it's broken, because everybody knows it's broken, even the parents know it's broken, the kids know it's broken, the kid has to get registered before we can get medicine, especially controlled substances, out of the Pyxis machine, and then they have to confirm the allergies, and if it's not ordered, there are so many steps that happen that it does significantly delay a lot of kids' pain. You can give it intranasally, you can give it IM if you need to, There's lots of different ways. So IV or IO access shouldn't be a kind of deterrent for you either. All right, now let's kind of get into some of the meat and potatoes about this, right? So the lethal triad, you'll remember from adult world, the lethal triad is the same in the kid world, right? So hypothermia, you have initial blood loss, you have exposure because they're tiny and you've gotten them naked. And kids in general have poor thermal regulation. The littler the kid, the bigger their head. That's why I always put, the hats on the babies because they lose all their heat through their head. So part of lethal triad, you get hypothermia. Kids will get hypothermia much more easily than their grown-ups. For coagulopathy, they have an immature coagulation system. So especially if you're less than 6 months old and you have inhibition of clotting factors, all little babies. And then you wind up getting acidotic. So hemorrhagic shock will give you acidosis. Tissue damage from your actual injury will give you acidosis. When you combine hypothermia, acidosis, and coagulopathy, that is the lethal triad. And it starts this horrible downward spiral of death. And that's what you want to avoid. So if you can work on treating the hemorrhagic shock that worsens the acidosis, if you are giving, whole blood that might have some clotting factors in it, maybe that's kind of how you can help with the coagulopathy. If you're keeping the kid warm, giving warm blood if you're doing it, kind of preventing that initial blood loss with tourniquet application, that can help with the hypothermia. You can help stave off that lethal triad. So I want to talk about TXA, right? TXA now in the protocols for kids 5 and up, under 5, medical consult, may or may not get it, just depending on the situation. TXA, tranexamic acid, has been used in kids for a long time inside the hospital, cardiothoracic surgeries, maxillofacial surgeries. They used TXA all the time. The battlefield used TXA. Back in 2010, the CRASH trial came out. It was CRASH 2, and basically showed that TXA decreased the mortality and the bleeding deaths. There were some younger people in it, not a whole lot to be able to say, hey, let's use this in all ages. But the CRASH 2 trial really highlighted TXA. After that, you had kind of 5 years later, 2014, 2015, you had the Pediatric trial. I love the names of some of these studies. The next one is actually my favorite. But Pediatric was done in Afghanistan. It was close to 800 patients, but they were all less than 18. It was a retrospective trial. And basically, based on physician discretion, the kid got TXA or a subsequent dose of TXA in the hospital. And so they looked at the mortality. The average age was 11 years old, which was a really nice study because a lot of times in these technically pediatric studies, they use 18 and under, and most of their kids are teenagers, which doesn't help us with the 2-year-old, the 3-year-old that has the different pathophysiology. But this study, at least you got down to an average age of 11. They had 10% of their patients received TXA. There was no increase in complication rate, which is what people worry about in terms of like DVTs or pulmonary embolisms. And there was actually a decrease in mortality in that group. So the Pediatric trial set the stage for what is currently going on, which is the TikTok trial. And I'm fairly confident that this TikTok was named before the app TikTok. But what this is looking at, and it's still ongoing, still enrolling, is in kids with chest trauma and head trauma, is TXA beneficial? And so they are doing a double-blind randomized control trial, which if you like research, that is like the best kind of research that you could ever do in your life. So very good. So they're doing either placebo, so like normal saline plus a normal saline infusion in the hospital, or a dose of 15 mg per kg, because we don't know how much to give kids, right? Grown-ups, we give a gram, who knows? 15 mg per kg followed by a 2 mg per kg infusion over the next 8 hours, or 30 mg per kg with a 4 milligram per kilogram per hour infusion over the next 8 hours. So we're doing those 3 different things. This trial that's listed here at the bottom, it was the kind of the feasibility to make sure they weren't killing off a lot of kids. When they were doing it, they had 31 kids with a mean age of 10 and a little over 10 and a half. And they found no difference in global function and blood transfusion rates, intracranial hemorrhage rates, or adverse events, DVTs, PEs, other clotting things. in that. So small number of people, didn't show the mortality benefits, but it wasn't powered in order to do that. This was more, am I going to kill the kid with it? And they did not. So very reassuring. This will continue for the next couple of years. It's another PCARN initiative study. And I would imagine in the next 3 to 5 years, we may have a little bit of an answer. There have been some small trials looking at TXA in general in closed head injuries. The ones that I've read haven't really panned out to any benefit. Where there might be some benefit is the mild to moderate head bleeds, not the severe head bleeds. But there haven't been any complications related to the TXA use. And that lack of complications in kind of all of these studies is one of the reasons that it was able to go out into the protocols, even though we don't yet have what is the ideal dose in pediatrics. So the next question you have to answer is, what fluids do I want? So I mentioned earlier that kids will lose 40% of their blood before they become hypotensive. They're going to present tachycardic, altered, delayed cap refill, things like that. A couple of years ago, right? So if you've been practicing EMS for a long time, at one point, you would have been told to give 60 milligrams per kilogram or mLs per kilo of isotonic fluids, your normal saline, your plasmolite, whatever floats your boat. And that actually worsens coagulopathy, it worsens acidosis. You know, a lot of them are not completely as physiologic as we would like to believe they are. And so the guidelines have finally been revised. And this was a big deal. So it finally went from recommending 60 cc's per kilo of fluid to now recommending 20 cc's per kilo of fluid prior to initiating blood products. The problem was, okay, so yes, blood products, but what kind of blood products? Because traditionally, and in a lot of the initial research, had been packed red blood cells with platelets with frozen plasma. When you put the three together, you generally get whole blood minus a little bit of missing stuff. But was that the right thing to do? Nobody could ever figure out what the right ratio of those products was in kids. And then adults started using whole blood and found out, like, oh, this whole blood is wonderful, and we only give one thing, and it contains all the other things that we need, and it's actually what the patient is losing on the floor, losing into their belly. And so they had to figure out whether whole blood was safe to give in the field, could paramedics give it, and did it actually help? And that way they never had to answer the question of what's the appropriate ratio in massive transfusion. So this study was one of the first ones, and you'll notice it's from 2022, so not that long ago. The research in pediatric whole blood has skyrocketed over the past kind of 1 to 2 years as blood has made it into the field in different areas. So this trial was on patients who were being transported from another hospital via helicopter or ground EMS units to a level 1 pediatric trauma center. And they were able to say on day A, everybody got treated regularly. They got their fluid amount, which was 30 cc's of crystalloid if they needed it. And on day B, you got 30 cc's of crystalloid, but you also got blood if you needed it. And what they found was that the group that got both crystalloid and blood actually had lower transfusion rates when they got there, which makes sense because you gave them blood, but they also had improved lab values and an improved shock index on admission. Now, that in that particular study, they didn't see any increase or any difference between the two groups in the total amount of blood products they needed during their hospital stay or in mortality, but they also didn't see any complication rates. So one of the takeaways from this study and kind of studies very similar to this was that EMS can give pediatric patients blood, and it's okay. You got to prove things kind of slowly and surely in the children. Now, this next one was pretty cool because this was whole blood therapy versus what they referred to as component therapy, which is the red blood cells plus the platelets plus the fresh frozen plasma. And they took 135 kids that got whole blood. And what they showed was that those kids that just got whole blood, as opposed to kind of piecemealing everything together, they had less ventilatory days and less ICU days compared to the other patients. There's the same mortality between the two groups. But this was a kind of another study that was showing that whole blood is safe to give in kids. Now, what are the ultimate recommendations? This is hard because these studies had a couple hundred kids in them each, right? And are we ready to generalize those smaller studies that are not the randomized double-blind controlled placebo studies? Are we ready to generalize that to a whole bunch of vulnerable children? And some people say yes, some people say no, but what you rely on is consensus statements from expert groups. And one of the expert groups is the Pediatric Traumatic Hemorrhagic Shock Consensus Conference recommendations, which sounds like a wonderful group to make wonderful recommendations. And they came together last year and met and kind of published these couple that are listed here. One, they recommended the use of blood products over crystalloid. Excellent. The use of low titer O blood, so whole blood, over individual component therapies. That was a big push towards whole blood, which is wonderful. They said it was reasonable to consider pre-hospital transfusion. And that's, again, a big push from when this was kind of came out in 2022. The whole blood was just entering the field. So the fact that and pre-hospital blood was still very new, especially it was only kind of done in a couple of different states. They said TXA within 3 hours might be considered. I think they're waiting for the results of the TikTok trial before they make any further recommendations. They recommended tourniquet use. Now you might say, why wouldn't they think tourniquet use is a problem? But tourniquets aren't studied on kids because most kids don't have their limbs amputated in that way. But now with increasing penetrating trauma, increased kind of war injuries, explosives, things like that, kids are getting more and more injuries that would require tourniquets. There's a handful of studies that are sponsored by the tourniquet makers that look at, does the tourniquet actually work in kids? Because think of that little 6-month-old arm. You have to be able to kind of crank your tourniquet to the point where it would actually cut off the circulation in the kid's arm to be able to make their pulse go away in order for the tourniquet to be effective. So they did some studies on healthy kids. They only went down to the age of 2. I don't know why, but that's just what they did. And they found that their tourniquets worked in kids down to the age of 2. One of the brands had a failure because the kid cried. And I don't really blame him for crying, so I don't know whether I would have considered it a failure, but they couldn't make his pulse go away because he was screaming too much beforehand. All right, fair. So tourniquets can be used when you look, depending on which particular tourniquet brand you're doing, you can compare their smallest compression to standardized charts of baby limbs. So there's published kind of growth charts and say like, okay, an average 6-month-old's thigh is this much. And of the tourniquet brands that I had looked up, yes, they will fit around a 6-month-old's little chubby thigh, which is good. They also recommended against permissive hypotension. So that was big a couple of years ago in your adult trauma patients because kids wait to drop their blood pressure so long. If you allow them to have permissive hypotension, they will just bleed more and more. And then by the time you're finally doing something about it, they will be at 60% volume loss, which would not be very good to come back from. All right, so the other important thing to add when you're doing blood transfusion is calcium. And the few studies that have been done looking at whole blood, TXA, and calcium use, they've all been bundled together. So I don't have a study that says I used TXA, I used whole blood, but I didn't use calcium. And it's becoming standard in your adult populations to when you give blood, you should be giving calcium supplementation as well. The study that was done in the South, they bundled, depending on the age, so greater than 10, kids who were suspected to be in hemorrhagic shock requiring blood transfusion got 2 units of this was before whole blood, 2 units of PRBCs, 2 grams of calcium, and 2 grams of TXA. Kids ages 5 to 9 got 1 unit of PRBCs, which is packed red blood cells, 1 gram of calcium chloride, and 1 gram of TXA. And what they found in the pediatric population is that they did not die. The kids that did not get this treatment, they died. So half the kids that were hypotensive on arrival that did not get pre-hospital blood wound up having increased mortality and wound up dying in the ICU. If they had gotten this kind of bundle pre-hospitally, even if they presented hypotensive, they did okay. So it suggests kind of similar to a bundle of care with high performance CPR in your pediatric medical cardiac arrest, your resuscitation of hemorrhagic shock and putting it in a bundle can actually improve your outcomes. All right, so now we'll jump into the traumatic cardiac arrest portion. We know in pediatric medical arrest that early epinephrine administration increases your survivability, but we don't have great data looking at epi use in pediatric traumatic arrest. This study is one of the first ones that have done it. So they separated kids into two groups. These were kids less than the age of 18. And the one group was hemorrhagic shock. The other group was, we don't know why, but they weren't bleeding out anywhere, type of shock. So they had 500, a little over 500 kids that were included. And they defined early epinephrine administration as less than 15 minutes from the time of cardiac arrest. And late epinephrine administration was greater than 30 minutes from the time of cardiac arrest. So it didn't matter what time EMS got there as long as the epinephrine fell within less than 15 or greater than 30. And what they found was in the hemorrhagic shock group, which was more than half of these kids, so give or take 300 kids less than the age of 19, the mortality was increased if you received epinephrine early. Now, between the two groups, yes, ROSC rates did increase. So they got them back when they got to the hospital, whether you had hemorrhagic shock or shock from some other cause. Your ROSC rates were better, but your metabolic acidosis was worse, your urine output was worse, and then if you got epi early, you died more. So does epi increase ROSC? Probably. Does epi worsen your mortality? Yes. So similar to the data that we see in adults in bicarb and calcium in cardiac arrest, think of that in epi and traumatic arrests. Maryland has taken epi out of grown-ups for traumatic arrest. Of course, you roll into a lot of hospitals, the first thing they do is give epi. I can't comment on that. We do not have enough literature one way or the other to definitively take epinephrine out of pediatric cardiac arrests. There's still kind of a lot of discussion and a lot more research that needs to be done. But if you just take this study, this small group, it suggests that epi may increase mortality. This one just kind of came out last year and looked at similar things. But it basically also showed that kids who got more doses of epi in traumatic arrests did worse. Similar to kind of in pediatric medical cardiac arrests as well. The more epi you get, the worse that you did. So we'll jump from epi to needle decompression. Remember way back, we used to do second intercostal space, midclavicular line. Then when the adults switched over to the fifth anterior axillary line, then there were some liver and spleen biopsies. And so pediatric protocol moved back up. There is a bunch of literature trying to figure out where is the ideal location for all kids in terms of needle decompression and how long the needle should be, how big the needle should be. This one article that was out from a couple of years ago tried to figure this out based on CT studies. Now, these were just kids who had CTs for whatever reason they had CTs for, and then they measured where the landmarks were, where the lungs were, and where you're going to hit the liver, where you're going to hit the spleen, things like that. And these were the answers that they came up with for this particular group of people. Now, I will say the length and size of needles for pediatric decompression has been talked about at Pediatric Medical Review Committee or Pediatric Medical Advisory. I forget what PMAC stands for, but it's been discussed at the Pediatric Protocol Review Committee version. And basically, they don't make the ideal needle in the US to be able to follow kind of all of the recommendations of everybody. But I will say it's probably safer to go the second intercostal space midclavicular line compared to the anterior axillary line. So in addition to these measurements, the other reason that I say this and this article just came out like last month, maybe the month before. This was a study that was looking at should ultrasound be used when chest tubes need to be placed. And so they just took kids who came into the ED, they used ultrasound, and they used the fifth intercostal space anterior axillary line as their landmark. And you can see it in this picture of this little kid right here. Look how high up that is. This is kind of a lot of times people count erroneously, or people are super, super chubby, and how we wind up kind of putting a needle in down here, where this center right here is really that kind of fifth intercostal space, the anterior axillary line. So they measured where that was, what the lungs looked like as the kid was breathing. And they found that 25% of the time when the kid was just breathing normally, their diaphragm came up to that line. And when kids were taking, they asked kids to take really deep breaths and measure, 30% of the time the diaphragm came up above the fifth intercostal space. So that's why it may not be the ideal location to put in a needle without kind of hitting those underlying organs that you really don't want to do. Now, how good do kids do? Kids are more resilient than grown-ups, but how good do they do if they actually suffer a cardiac arrest? So this table in the next slide is kind of a continuation of the table. And this particular study, this was 11 years of data, and they only got 23 plus 25 kids, right? So, and this was at a pediatric level 1 trauma center. So not that many kids present in traumatic arrest. But what you'll notice, when pre-hospital ROSC was obtained, the average age was 9. When no ROSC was obtained in the pre-hospital setting, these kids were younger, kind of around 4. Then I want you to look down here at the bottom, the type of injury, just to get a sense. The majority of these kids in traumatic arrest are blunt trauma, right? Your MVCs, your falls, things like that. They're not the penetrating injuries, shot, stabbed, things like that. And blunt trauma carries a much worse prognosis compared to your penetrating trauma. And in general, your penetrating trauma is probably going to be treated more similar to your adult penetrating trauma, as opposed to trying to compare blunt pediatric injury to adult blunt pediatric or adult blunt injury. So same data set that they were using, but a breakdown of the mechanism of injuries. And you can see motor vehicle collision is one of them, not accidental trauma, burns, hanging was fairly significant, especially with those that got pre-hospital ROSC. And a lot of that is because it's an airway compromise issue, or they broke their neck and they lost their drive to breathe, and you got ROSC because their hearts are healthy and you kind of put back their breathing apparatus. So of the kids that had CPR at presentation, so never got any pre-hospital ROSC, they started with 25. The majority of them went to the morgue, were pronounced in the ED, and the rest of them went to the PICU. When you look at the kids who got ROSC pre-hospitally, most of them went to the PICU. 6 were discharged alive. Of those 6 that were discharged alive, only 2 were discharged neurologically intact. So overall, fairly poor prognosis for pediatric trauma. But the suggestion is if you get ROSC during that initial phase of resuscitation before you get to the hospital, your outcomes are likely much better than if you don't get ROSC until sometime into their ED stay. So we'll talk about pediatric tour for a few minutes. And this is a paper that was published. You'll recognize Dr. Anders' name in here. Dr. Fish was a Penn Fellow at Hopkins before she moved back down to Florida. And they were really instrumental in developing both the pediatric medical tour protocol and the pediatric trauma tour protocol. Maryland is one of the first states in the country to have a pediatric tour algorithm. So it's really kind of cool that we're leading the front on that. This paper has both how they developed their medical protocol and their trauma. We're just going to talk about the trauma portion, but if you ever want to go read it, it's a lovely study. They basically had access to 8 million, that's a lot, this is data from 2019, 8 million EMS calls. But when they kind of dove down into the numbers for pediatric patients and pediatric trauma arrests, where we actually had the data, all the EMS data there, They had about 200 patients that they could look at. This is the tour protocol that they were proposing, and this list is how they actually used it in the data set that they were doing, because certain things are not going to be able to easily be pulled from the data bank. So this is what they equated as the same. What you will notice is they wound up with 138 patients that were able to be included in the study, because the others were missing data, things like that. So they had 138 complete patient records for traumatic cardiac arrests, and they limited it to 0 to 14, which is where this 138 came from. When they took the TOR protocol that they came up with, they got correct 27. So 27 were TOR eligible by protocol. And when they looked at, did they get ROSC in real life, 4 of them got ROSC in real life, but 3 of them were drowning. So like I said before, drowning, you just throw out a trauma, you throw out a medical, you treat it completely differently. And so if you take those 3 out, then you only had 1 that would have been TOR eligible that did get ROSC. What's missing from the study is the link to hospital outcome and hospital discharge. Just the way that data set was set up, they didn't have access to that. But this study is one of the reasons that pediatric medical tour and pediatric trauma tour are included in Maryland Medical Protocol. So I'll mention mechanical CPR because sometimes we get a little flack from our local trauma centers when we bring in adult or teenage patient on, for us, the Lucas. And we know that it doesn't improve morbidity or mortality, but it does improve EMS and fire department satisfaction, and it produces much higher quality CPR than we're able to do in the back of a medic. So what I want you to think about is how low can you go with age? Certainly it is a size issue, right? We've all seen patients that are too big for the Lucas to fit around, and we've all had frail little old ladies who the suction cup doesn't get down to their chest because they're so teeny tiny. A lot of people will go down to about the age of 13. This photo that's included here was based off of a case study of it being used in an 11-year-old where they wound up padding the back, and they actually got ROSC on this kid. Please don't do it without your medical director approving it. But you may likely see case studies of the Lucas being used down to a lower age, especially when prolonged CPR is needed. So like your hypothermic arrest during rewarming or things like that. But you can certainly use it in traumatic arrests, presuming that there's no like active bleeding under the suction cup or something like that that's going to need physical hands in there. This is also when you look at, we use CodeStat to be able to give these wonderful kind of data analysis. And what you'll notice is these little hash lines, which are theoretically bright red, are the actual compressions. And they're beautifully timed. You can see the compression rate beautifully at 102 from here to here where the Lucas was used. This was up here, manual CPR, and you can see kind of these white patches are pauses. In that the period down here was a period of ROSC where we didn't need to be doing CPR. But you can see that the Lucas does give you nice regular compressions, and this was from a teenage patient. Now, what's you need to know is the magical number for how high their chest needs to be. And that magical number is 17 for their diameter of their chest. And when you look at what age a diameter of 17 correlates with in general, assuming normal growth patterns and things like that, you get to kind of right around this 13-year-old age range. It can almost be 11 like it was here. This study looked at the diameter of Asian children, so a little bit of a different population than ours, but kind of a rough number on how you can do that. Certain interfacility groups, so I know Hopkins Peds Transport was working on coming up with a measurement so that before they got out the Lucas and stuck it on somebody, they could actually just take their measuring device and kind of hook it over the patient and say like, yep, they're 17. Okay, the Lucas is going to work. Let's do that, which is a very cool and innovative idea. Now, Reboa is kind of off and on in popularity in the adult world. There's some research that says it's really cool and it really improves morbidity and mortality. And then there's some that say, nope, they just die. So why do it? And what Reboa is a catheter through the femoral artery so that it goes up into the aorta, and you basically blow up a balloon. So it cuts off circulation, in theory, below the area of injury. And you can do it kind of in a low zone, so below where the kidneys come off, just if you had like a significant pelvic injury or something like that. But you could also, as you see kind of in this picture here, you can go up to right where the aorta is coming off the heart and cut off all that circulation. Now, the problem is size. So the catheter is, your aorta is only so big. The catheter is big in general. So really the age of 12-ish is probably, with the commercially available products and Reboa kits available now, is probably the smallest that you can go. The pictures here are from a case series on a 7-year-old who had a cardiac arrest after a motor vehicle accident, got a lot of CPR, and was found to just have a ridiculous amount of blood within the belly itself. And what they did was they placed a Reboa catheter up kind of to the top, right where it came off of the heart, and were able to take that kid get that kid stabilized enough to go to the operating room, open his belly, fix the aortic injury that was there, and then get him to the ICU. So they used it as a temporizing measure to stabilize enough to get the kid over. Now, unfortunately, the kid died of other injuries. He had disseminated intravascular coagulation in addition to significant head injury, and wound up dying because of those two things. But this case was the youngest case of Reboa that's been published back in 2020. Just showing that it can be done in earlier kids. This is definitely not something you're going to see in the field anytime soon. You may with the GO team. Some of the GO team physicians are certified in placing Reboa and have the potential to do that. We haven't done it yet at all, and you wouldn't see it in the field be done on a pediatric patient. So ED thoracotomy, right, where they cut open the chest to expose the heart, very controversial also in the pediatric population. If you take patients into trauma, you would think they would thoroughly enjoy cutting it open, because it seems like all of them wind up with a thoracotomy when they're in arrest. But the recommendations really had not existed until about 1 to 2 years ago for what to do in pediatric patients. For one thing, if you do not have a surgeon, you do not do the thoracotomy, because once you get in there, if you are not a surgeon, you do not know how to fix what is wrong. So this would only be done at a trauma center that has a surgeon who's going to be able to fix the wounds. Up until the study that's on the screen was published, the lowest survival ED thoracotomy patient had been 9 years old. This was a case study of a 3-year-old that had an arrest, had accidentally shot himself at home, was brought in, arrested in the elevator, kind of got put in the resuscitation bay, got a thoracotomy, got resuscitated with massive amounts of blood products, and actually wound up surviving and being discharged a couple of weeks later, just with some bowel injuries as kind of the permanent thing. I will say this particular patient did not have any significant vascular and or cardiac injury. So that probably played a role into one of the reasons that he survived as well. These are the consensus guidelines from the Pediatric Trauma Society on when the hospital should consider an ED thoracotomy. And you see kind of the columns for pediatric and for adult. And what you'll notice that is that for pediatric patients, it's only when they present to the ED or to the resuscitation bay, whatever you want to call it, with signs of life. Now, they consider signs of life being electrical activity, meaning the kid could be in PEA and otherwise dead, but that would qualify as a sign of life. They also include respiratory effort, pupillary response, pulses, blood pressure, or extremity movement. But the PEA is kind of key in whether or not they will recommend a thoracotomy. They, for penetrating trauma, penetrating abdominal or pelvic trauma, and then the blunt trauma, blunt injury. For peds without signs of life, they're not going to do a thoracotomy. And quite honestly, I don't know how many trauma centers have jumped on board with this, because this just came out at the end of last year. All right, so to kind of sum up what we've talked about today, the general approach, remember to go alphabetically with kids, their airway, their breathing, their circulation. If they're hypotensive, they have fallen off the train and you really need to try to get them back on the tracks. Remember their neurological exam, remember to monitor their sugar because they will drop, they will become hypothermic. Try to deal with the family as best you can. If you happen to have extra staff, or somebody off the engine or an EMS supervisor who is not directly involved in patient care because for some odd reason you have too many paramedics, I don't know, be a luxury. If there is somebody that you can dedicate for mom, for dad, for grandma, whoever it is, that can significantly help to kind of be that liaison person. We talked about the improved morbidity and mortality at pediatric trauma centers for kids. Talked a little bit about ultrasound. I think over the next like 5-ish years, we will see most jurisdictions getting involved with ultrasound. We will hopefully start seeing more and more jurisdictions involved with blood as well, which will be super exciting. We will have kind of the results of the TikTok trial and whether or not we should be giving TXA, and whole blood will hopefully come out as the winner and stay the winner on top in kind of all the studies that are still undergoing patient enrollment. For traumatic arrests, I don't know if we're ever going to have the answer of whether epi worsens morbidity and mortality, just because the rates of pediatric traumatic arrests are so low, especially compared to the adults. We might, and if we do, it may come out of the protocol similar to you see it as adults, but for right now it's in there. Pediatric tour for trauma arrests is in protocol, which is wonderful. The caveat is, of course, appropriate social emotional support on the scene, which is a rarity. I don't have good numbers for when we do pediatric tour outside of that like teenage population street corner. So I don't know. And quite honestly, most of them we wind up transporting because it's dark and we're on a street corner. And there's typically a lot of people who are not necessarily family members around us. And then rubella and thoracotomies are not going to come to the field, but you may start seeing more and more case reports as more and more kids suffer those adult type injuries and those penetrating traumas that we're not used to seeing in that population. All right, so thank you. What is listed here are a couple of my favorite easy free resources for people. So if you are ever kind of interested in why we do what we do at the hospital, and like if you take an asthmatic in, what is the pathway that we follow? If a 1-year-old has a fever, what do we do? CHOP, Children's Hospital of Philadelphia, publishes their clinical pathways online. A lot of other hospitals use them. They're great, they're easy, they're interesting to look at if you're into that sort of stuff. They also do a pediatric emergency medicine podcast, which it wouldn't be the top of my list here to follow, but it does have some nice information on there. Don't forget the Bubbles is Facebook, and you can just Google it. They're based out of England, so a little bit of the care is different, but really cool pediatric information, very good summaries of why we do what we do. The National Association of EMS Physicians has a But Why series. Over the past year or two, they've intermittently published, but it's free. You can, when they're current, you can get Con Ed for it. They have, from a couple of years ago, a very nice series on medical pediatric trauma resuscitation that will make you cry, but just explains things so well. Very good. And then you have a bunch of different podcasts that are listed below that are all free and very interesting. And so thank you. And if you have any questions, I'm happy to answer them.
Thank you so much. It's a topic that we're forced to have, that it's very uncomfortable, but this is what we do. It's interesting, the stuff that's going on with whole blood, which is just starting and rapidly increasing. I was involved with a lecture on that earlier today over at Sinai. But it makes sense. There's lots of lots of research needs to be done. It's very hard to get good controlled studies. So most of it's all going to be retrospective. If there's any questions in the chat. Remind everyone that if you would like credit for continuing ed for MIEMSS, go to the chat, hit the link, fill out the information, give yourself a copy so you can keep a record of it. The next topic will be, we're going to take off for the week of Thanksgiving. Week after that, we'll have Dr. Chismar from MIEMSS giving a talk. I think Raboa will become one of the future areas that are looked at. That and the whole blood.
And then the role of organ harvesting in kids who have died, certainly. Pediatric transplants, very needed, unfortunately. But depending on what they have died from, they can certainly, living legacy definitely gets involved. Is Raboa similar in function to a balloon pump but placed differently? No, it's literally just a balloon catheter that gets put up there and inflated. So no pumping action whatsoever, just trying to occlude the bleeding.
It's placed in the same manner. It's just an internal aortic cross clamp. Anyone has any questions, feel free to speak. You can still type it, but other than that, I think we'll start to wind down. Thank you so much for today's presentation. It was very informative on a very difficult topic.
All right, thank you guys.